Dave Otway, are there any stats on rate of recovery of patients who required ventilator care? So yes, the stats on mortality rate, fatality rate keep changing, and they're changing dramatically based on what we call the denominator. The numerator would be the number of people that died. The denominator is the problem. And you know, when you go to Hopkins, you spend time there, you get a lot of, you know, the snobbery, but there's a lot of appropriate stuff too. What they talk about is numerator medicine, and that is, what is the actual number on the bottom of the ratio? So the stats are still going to continue to go up and down. What you typically see overall with any of these outbreaks is that you get a much higher, you saw it with Ebola, you saw it with SARS, you see it with most of these new bugs. Death rate comes out a lot higher because death is hard to miss. On the other hand, just having a mild cough and sore throat, especially if you don't know the disease even exists, it's hard to find the number of people that were actually in the numerator. Now, I don't know if that helps Dave in terms of understanding. Here's another way of looking at statistics for the people that went into ventilator care. Usually once you get into ARDS, acute respiratory distress syndrome, in the past, 10, 15 years ago, mortality rates were like north of 40%. Once you start making, we've made some of the changes that we've made. Number one, a little bit lower vent tidal volume. Number two, paralyzing the patient so they can't fight the ventilator. Number three, putting the patient over on their face. You went from low 40s down to low teens. So significant continued improvements. Now, is the data significantly different on that for people that go into ARDS or respiratory distress from COVID? I haven't seen any indication that it's significantly different. But again, you start adding some of the hope that we see with things like the antiserum. So folks that start getting that sick, adding antiserum, there are trials going on with azithromycin and Plaquenil, those types of things. And we even talked about, and don't throw rocks, but there's been a lot of research. Some of it's been on high dose vitamin C. So there's a lot of things going on right now in terms of treatment. And I think you're going to see, I'm a big fan of the antiserum thing that we talked about today. Plaquenil, probably. Plaquenil, azithromycin combination, maybe a little bit better. Again, both of them significantly dangerous. Vitamin C, not so dangerous. What's it going to look like? Again, don't know. But I have a lot of expectation that the antiserum is going to be helpful. There have just been too many examples of where it worked. It's been too reliable in the history of medicine for dealing with these large outbreaks. And you hear this statement, and you hear it multiple times. Is the antibody completely protective? We keep hearing that people have gotten infections after developing the antibody. Well, that's true. You do keep hearing those. I haven't seen a lot of significant science behind that. And here's the thing, there are viruses which some antibodies work, most antibodies don't. For example, HIV, that's a big focus in that area and a big challenge in terms of managing that outbreak. But I do think if that were a major problem for management of this outbreak, COVID-19, then we would not have seen the things that we've seen. The last time I looked was maybe up to a week ago, and I think item number 3 on the standard statements, reliable statements from the CDC about COVID-19 was, once you have the antibody, you're not infectious anymore. So I do think the antiserum is going to become very helpful as we get our arms around how to make it quickly en masse. There's also a lot of interesting things coming up about ventilators. There's the open source ventilator idea that I covered it, I think, after the YouTube channel choked up and dropped us. But there's some open source designs for ventilators. New York, for example, has already announced that they're doing some trials of doubling, using 2 ventilators for 1 person. That doesn't scare me nearly as much as it scares some people. I think we're going to greatly improve our capacity for developing PPE, personal protective devices. I know that the group that I'm working with the National Testing Program, they've already created more cottage industry right here in Kentucky, developing masks, taking Tyvek, buying Tyvek from Lowe's and using it to make gowns. It's like very, very innovative stuff. So I'd like to talk with you a minute about the webinar. People don't understand what the webinar is. It's actually a great way to get some access to healthcare that you're just not going to get any other way. You actually get the lab tests yourself at a local lab, a Quest lab near you, for the inflammation panel and the OGTT and the insulin survey. These are things, inflammation and prediabetes, that your doctor just does not know about. And here's the thing. Harvard Health and many others have said, look, sudden death is not always so sudden. The Hollywood picture that it's a bolt out of the blue is not realistic. It's more like real lightning, preceded by clouds, wind, and rain. Stop that metabolic storm before the lightning strikes. And here's where that metabolic storm comes from. It's inflammation, and it has to do usually with prediabetes. So again, we actually get labs, we go over them in the webinar, and then you can start finding out how you can prevent that heart attack others said that you couldn't even predict. We can show you how. Thanks.